everybody could just make sure that you're muted and so that we don't have any kind of interference with conversations, it makes it hard for us to keep going. So just briefly, we will, after this presentation, today we'll have a link that will appear and for CME and CEU credits. So I want to go ahead and introduce who's with us today on our hub team. We have Dr. John Allen, who's a clinical psychologist and retired in 2016 from his position as clinical professor of psychiatry from the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. And he has continued to teach and consult and write books in what he has called his retirement. And Ross Ellenhorn is a PhD, is a sociologist who's also trained as a psychotherapist and is the owner of Ellenhorn, a very robust program in the United States focused on providing intensive psychiatric and psychosocial care for individuals in their own homes and communities. His current writing is about the intersection between interpersonal experiences of holding and larger societal and cultural forms of holding, and the latter's function as a buffer to loneliness, anomie, and emergence of totalitarianism. And we have Michael Grote, who's the president and CEO of the Lindner Center of Hope, which is an affiliate of the University of Cincinnati College of Medicine, where he's also associate professor of psychiatry and neuroscience. Dr. Grote trained in psychodynamic psychotherapy at the Austin Riggs Center and has spent his career working in hospitals and residential programs, including the Menninger Clinic, Silver Hill Hospital, and Cooper Reese. He has a passion for collaborative, flexible care that meets people where they are in a compassionate manner. And I'm Jeff Katzman, and I am a psychiatrist and run the education programs at Silver Hill Hospital, director of our Silver Hill Academy for Research and Education. Look us up and look at our events program. We have all kinds of things going, including collaborations with the Mentalizing Initiative, and a 7-week program about that ongoing right now, and many grand rounds and other programs. So with that, welcome everybody. I'm going to turn to you, Ross, to introduce our guest, Robin, today.
Yeah, I was thinking about Robin, and I was thinking about this kind of creeping sense of loneliness that happens when you believe in the kinds of things that we talk about in this series, and how you don't know that loneliness until you find somebody who has that same ethos and actually places it front and center in what they articulate about their things. And the first time I met Robin, I knew I was less lonely. I noticed my loneliness, but I also felt home. And it's just a joy to get to know her better and better. And Dr. Robin Kissell is an associate professor in the Department of Psychiatry at UCLA and training and supervision analyst at the New Center for Psychoanalysis in Los Angeles. An educational background blend. She has an educational background blending the arts and neurosciences, and that led her to the study of medicine and ultimately psychiatry, and developed into a career devoted to the study and treatment of personality. From 2006 to 2016, she directed a residency training program, the UCLA Borderline Personality Disorder Initiative, modeled after the original mentalization-based treatment program at Holloway Hospital in London. She now directs the Mentalization Initiative, a nonprofit dedicated to training clinicians in mentalization-based therapy and educating the public about mentalization as a means of connecting. I welcome Dr. Robin Kissell.
Thank you, Ross, for that lovely introduction. I'm less lonely too. Thank you. Okay, let me just share my screen for a couple of slides here. Okay, so today we're going to talk about the process and what I think of as a real challenge in terms of containing. And I'm just saying that I'm in compliance with the ACCME standards, that I do not have any relevant financial relationships or anything to disclose for this presentation. And our objective today is to talk really about what is containment and containing, why it's necessary, and also to share with you how I see it linking with mentalization. And with that, I'm going to turn off my screen or my sharing so that I can just kind of talk to you about containment and so that we can have a discussion. I think, our first session, this whole series is about how we bring ourselves to our patients and into the room when we're in the consulting room and we're doing therapy. And John eloquently in the first session talked about relating and how hard it is to be ourselves, especially in this day and age when we're having to rely on formulatic treatments and diagnoses, and we're under the pressure of insurance. But what a challenge it is for us to be spontaneous and bring ourselves to a session. And then Jeff took that another step and talked about being playful and spinning off of the whole idea of mirroring and connecting, mommies and babies connecting through mirroring, and then collaboration and improvisational theater, and how do we play and converse in a session. And then Ross went on to talk about holding and the importance of being held, which really means the importance of being seen accurately and making a connection and feeling known and feeling safe, being recognized. And so today I want to take us to kind of shift us to something that's called containment. And I do this because I'm so aware of having to contain all the time, and largely because I see a lot of personality disorder patients, patients with neurodivergence, and even psychosis. And what they bring into the room is often a lot of intense affect, very chaotic thinking that doesn't always obviously make sense to me, that there's always a sense of discontinuity, that one day you're not knowing what you're going to get from the other day, that it's not continuous. And so how do we keep our mind when we have all of this being presented to us? How do we not feel alone? How do we feel ourselves and use ourselves when we're under a deluge of material coming from us? So this idea of containment, it may have started with Jung, but it was most elaborated by Wilfred Bion, who some of you will know and some don't, was an analytic thinker, a psychoanalyst with the British Psychoanalytic Society. He was trained by a fellow named John Rickman and Melanie Klein. He had a lot of experience on the front line in both World War I and World War II. And from those experiences and from his work with patients with psychosis, he was very interested in thought process and how the mind worked, and in group processes and the primitive nature that group processes can yield. And he was taken up by the whole idea of projective identification, which I think most of you will know is about a patient's need to project off very uncomfortable parts and find them or locate them in the therapist or other people. By projecting off, we feel better about ourselves. We feel rid of uncomfortable pieces. And at the time that Bion was working, he saw projection was being discussed as a defense, but he saw it as a means of communication. And he did that from his work with observing infants and mothers, and also from his thoughts about being on the front line and understanding people, but largely from infants and others in his work with psychotic patients. And so trying to understand, how do we understand one another? How does this process of thinking and being thought about developed? And you can hear in some of this the overlap of the work of mentalization, if you know anything about that. Peter Fonagy, who is a developmental psychologist and a psychoanalyst, began to also look at mothers and babies and how we develop this process of thinking. And Anthony Bateman, who was working with personality disorders and was frustrated by how come they're not getting better with just our psychoanalytic theories, they came together and began to look at again, how the caregiver and a mother is highly responsible for bringing a thinking human being into the world, okay? That we learn to think through another's thinking. And they then spurred off of much of of Bion's thinking. So when we talk, what Bion talked about with containment, it's really a very simple process. It was outlined in a book that he wrote in 1962 called Learning from Experience. But it's the idea that a patient or an infant brings all of this raw, unprocessed, messy sensory experience into the world. And that the maternal function, he called it an alpha function, was to turn these beta elements into alpha elements. And that from the alpha elements, we can actually think about something. So the messy gets turned into a psychological representation or something that is made into an alpha element that can then be thought or even dreamed. The analogy that I often use when I'm teaching residents or whatever, it's as though, you're playing catch with somebody, that somebody throws you a ball, you catch it in your mitt, you kind of look at it, you turn it around, you feel it in a different way, and you toss it back so that it can be taught. Okay, it's this reciprocal process, but there is a processing element in the person who's receiving. So as therapists, we are containers, we're the containers. And what we are to do is to contain what the patient brings. Mothers or caregivers contain what the baby brings. Now, if you think about the word contain or containing, you think about, having to hold something, having to provide space for something, having to carry something within you or within this object. It holds something together. A container will keep a fluid together. We hold together and we restrain things. When Bion was writing about containing, he was also thinking about his military experience and how in a military setting, containment can mean keeping a force within an area, okay, keeping it restrained, keeping it from aggressing forward. So containment also has that kind of feel to it. It's about providing boundaries. When one is contained or when a substance is contained, it is allowed to take up space. It's allowed to be part of something, and it is held together. Now, you can think about effects of containers, and you can think about this as people like us as containers, or you can think about literal containers. You think about a can of soda and you put it in the freezer. Well, what happens is it fills up, it freezes, and it bursts, right? And we can be filled up and we can be ready or on the verge of bursting as containers. You think about how containers can involute or collapse on themselves. Think of your plastic bottles on an airplane. They suck down and they involute or they collapse. As containers, we can feel very drained. We can feel spent. We can feel like everything's been taken from us, okay? There can also be a containment when you have a can, say you have a can of soup, okay? That soup can sit on a shelf for ages, and what's inside doesn't change, and the container doesn't change. So there's a neutrality in that. If we think about that in a therapy setting, does that mean nothing's really happening? Does it mean that it's just safety? That's a certain kind of containment. You can have some kind of a plastic container in your refrigerator with last night's tomato sauce in it. If it sits there for a few days, I don't know whether something gets in it or whether there was something already in the tomato sauce, but it will begin to fester and mold or something will grow. So if something sits inside us too long, does that begin to kind of spoil or go wrong? So you can think of containment in terms of that we are the personified containers, but containers is also illustrative of what can happen to us. Now, I want to think about some of the things that Ross said last time we met, because holding very much overlaps with containing. And I think that you have to be held and to feel held and to provide a holding environment in order to go on and to contain. Because holding allows you to feel safe. It allows for trust to begin to develop. And you're not going to be able to fully contain unless those two things, I think, are already existing. Maybe they overlap in their development. I don't know what you all will think about this, but to me, it feels like the holding is the prerequisite to being able to contain. So containing allows us to process. It's the next step. It allows us to process, to play with the material that's coming forward. And ultimately, it's allowing us to make meaning out of something that's very raw and messy. Okay. Now, when we're containing, I was thinking about this, that, we're talking about being able to bring ourselves into the room, but I think it's a different aspect of ourselves than maybe what we've been talking about in the last 3 sessions, because it's not so much about being spontaneous. It might be, but it is about not being reactive, because we're trying to hold space to understand something. So we don't react. We don't want to fix the material that's coming at us too quickly. We don't want um, to have it fit onto theory too quickly. We don't want to give an interpretation based on our formulaic theory. We need to be able to sit with what's coming from us or at us. And we need to be able to allow, in a way, this free-floating experience where what the patient is saying comes to us. We think about the words, we think about the affect, we take in the affect, we resonate with it, we may or may not empathize with it, we may have thoughts about what was going on with this person last week. We let those come in, so we have some context come in. We may have memories of something from long ago that the patient told us about, but we may not. We may have our own memories or our memories and thoughts about what's been going on in our life in recent days or whatever. And all of these things are conjured up with us. And it's with all of those experiences that we may be able to take what's coming at us in this very free-form, amorphous, inchoate way and put a word or a sentence to it that makes sense or that makes a person feel understood. And I think the ultimate aim is to get to some kind of a truth, a sensory truth that resonates with the patient. Now, this is not easy work, okay? This is not easy work. And I was thinking about the idea that we're talking about ordinary therapy. It is part of ordinary therapy, but it's kind of an extraordinary process that we're all having to do this, okay? It can be exhausting. It can be burdensome. You can feel under pressure. If we can sit with something long enough, I dare say I think we can be informed, and that we use that information to be able to put this alpha function, put thoughts to things that are really far messier and more inchoate. Think about how a patient will fill you up with stuff and you can't let it go. You go home and you can't sleep because of it, or you dream because of it. I think all of that is part of a containing function. Okay. It's not pleasant for us, but we're doing it, and it's probably necessary. and it's probably something that we are providing for our patients, is that they've really gotten into us and we're working on it for them. Okay. So we're trying to sift out noise and we're taking ideas and we're trying to derive at or discover something that's salient, that holds a truth. Okay. Now, I think this is a luxury that I probably have in a private practice. I think of many of you who are in more of a clinic setting, and I think that that's harder because in a clinic setting, we do need to do this. We need to be able to process what's coming at us, but you've got the additional pressures of thinking about things like diagnoses and are you delivering the right care and is the person getting better? Okay, those are pressures that could really obstruct our capacity to contain. And I don't know what we do about that because I think it's a reality of psychiatric and psychological treatment these days. Um, but that said, I think you can also be mindful about your trying to contain. So we're trying to affect change, not so much by changing behavior or by giving a diagnosis and treating it, but by allowing one to feel seen and known and understood. And we're sorting out the different anxieties and sorting out to see patterns. And we're allowing for survival and we're allowing for development and growth to get stirred up again. Okay, that's a slow process that's not necessarily inherent in these clinical settings that we're often in. Now, I wanted to give you three little vignettes of real challenges for me in terms of containing and see whether they resonate with any of your experiences. Um, uh, I'm not going to give you much information about the patient. I'm going to ask the other thing I realized that has really helped me to be a more containing therapist is my understanding about mentalizing. And some of you will know that mentalization-based therapy developed in London with Peter Fonagy and Anthony Bateman. Mentalizing is our process of being able to understand ourselves, but also understand that the behavior of other people's comes from their internal world and their internal motives. And it derived from understanding how children think, little kids, that they don't mentalize very well. And most psychopathology is about when people have vulnerabilities in their mentalizing. And when one doesn't mentalize, they fall back on these very early ways of trying to understand the world, which are very original, very rigid. They're highly emotional. They don't have words to them. They haven't been put into words. So there's alexithymia. There's an inability to express really what's going on inside. And mentalization is based on being able to understand that minds are opaque. We really don't understand what's going on inside them. So, what it has allowed me is an ability to realize, okay, this mind is really different than mine. I don't understand it very well. I can be curious about it. It's given me a real freedom to to realize that a different mind, I don't have to be frightened of it. I can be curious about it. That my curiosity is now far more genuine. That emotion and all these weird ways of thinking are just the best way that that patient can do. And that it's something for me to sort out and apply my alpha function to, if I will. Okay. And it's allowed me to be comfortable with my not understanding, that I can also say to a patient, I'm not sure I understand. Can we think about this more together so that I can arrive at understanding? So my mentalizing, I don't think I'm doing a PR statement here for you coming to the MI, but my mentalizing has also helped to be able to be a better container. And so I appreciate it for that. And so these are my thoughts about containing, and I'm eager to see what you all have to say. Can't hear you guys.
Sorry, I was not allowed to unmute. I just got permission. I, Robin, that was beautiful. It has me thinking so much. It's so great to hear you talk about this and to hear your work. It's just spectacular. And I want to just say thank you to the whole group that's here and the chat that's going on. I really feel that we're in the presence of like minds, and I feel held myself with the technology problems that we had and contained by 45 chats saying do this and do that. What a great group trying to help. Thank you, everybody. So was struck also, Robin, by the baseball mitt analogy here of the ball going in the mitt and realizing that and the kind of mentalizing way of thinking about this, that you throw the ball back. Um, and like you said, sometimes in the containment it's a word or a phrase or something, but it gets refined, I think, right, by the other person. So you're actually kind of containing together. You're almost a team of we in the containment, so that it isn't all necessarily just on us as the container. But we have a teammate in the other person is just where my mind is starting to go also.
Well, I think and originally it's the therapist that has to contain it, but give it back in a form that can then be contained and then thrown back,
Yeah,
right?
yeah,
Yeah,
yeah.
yeah.
So that we're actually doing it ultimately, like the therapist has to make the first
Yeah, there's a refinement.
catch, but
Yeah.
yeah, but ultimately it's we're doing this together, and it's yeah.
Mhm.
No, Jeff, that does resonate with a number of comments in the chat. It's joining you on this. I mean, a brilliant presentation, Robin. Thank you. I mean, just your manner. Many people are commenting on your presence conveys soothing. Your presence conveys I'm an open container. I'm
Mm,
available for you,
mm.
which is very significant. Your openness and your stance. And so there's a number of questions that are kind of around this notion that we're discussing around the interplay between you and a patient and how much is kind of held between you, how much you hold at any given time, how it shifts back and forth, and what does it mean to sit with something? Can you talk a little bit more about that back and forth and what it means to sit with something?
Well, I think to sit with something, um, it's to sit with a lot of feeling that you may not know what it means yet. And so you have to sit with it in order to know what it means. You have to be patient. I think Bion would call it a reverie. And Winnicott would too, that you're in kind of a reverie state of sitting with it and letting it formulate in your mind. I was talking to somebody I was supervising this morning who is so quick to deliver a response that the response, he recognizes it as um, a representation of, say, aggression, and says, and this is, you're being aggressive because of this and this, when so much of the experience was missed. But this person in their anxiety, I think, wants to fix it. So they give an answer, they want to give an answer, which is really different than sitting with a lot of feeling, a lot of unknowing, a lot of letting you kind of walk around and with your own mind in terms of what's really being communicated to me here. What's the most important thing being communicated to me here? I don't know if that's helps enough, but that's what I think of.
I think so, yeah. There seems to be a lot of interest in, kind of this process of sorting out like what you're feeling and what is the patient feeling, what do you respond to, what do you hold, and as you really nicely illustrated, we kind of withheld an interpretation that could be accurate, but it didn't fit where the patient was, and it wouldn't have been helpful.
Yeah.
So it's kind of like you're guided by an ethic or a kind of a compass that says there's a discernment
Yeah,
in
I
what you
think so. I
share.
think I can also ask questions in that discernment so that if I don't understand, maybe I ask for a little more. Can you tell me more? Or what? So that I get more that I can use in my own processing. rather than assuming I can figure it out and delivering it, you know?
It seems like by doing that, you're also always communicating something that gentleman who was upset about being prescribed the medication is sort of a very direct version of lots of interactions where in responding, you're sending the message you can't contain it,
Mm-hmm.
right? But giving the quick answer, it's sort of saying to the person, I'm not really able to hold
Right.
your feeling,
Mm-hmm.
you know? Yeah.
Mm-hmm. Mm-hmm.
Yeah, I'd like to say your presence, which was commented on, is very containing
Mhm.
with that, and there's a kind of passivity that's very active. you,
Right.
you put
Okay.
together. But
Uh-huh.
I love the fabulous richness of your associations to the word contain.
Mhm.
I that was magnificent, and I think I'm struck by the physicality
Uh-huh.
of the idea of a container
Mhm.
and your associations to it, and the idea that the container itself needs containment, this
Uh-huh.
kind of back and forth. But it just attests to and I think from what Michael says, this is represented in the chat. This is who you are,
Uh-huh.
how you are.
Uh-huh.
And this is the inescapable and ineffable, aspect of what you're talking about.
Uh-huh. Uh-huh. Well, and we all think about how do we become how we are, whether my own analysis and my training and certainly the freedom that the mentalizing enabled me,
Mhm.
improv,
Yeah.
okay, Jeff. Um, all of these things, contribute to who we are. So I think I've certainly been in evolution over the years, right? Yeah, yeah.
Now, there's this interesting comment which plays on what you're saying, Robin, about one of the participants, Joan, says, Robin seems to trust the process.
Mm.
So there's something in here about your experience of sitting with, being open to, discovering. You trust that that might go somewhere. To some degree, you trust. You have some faith, I guess.
Mhm.
Can you say more about that? Like how you think you developed that sense of trust in the process?
That's a good question. I don't, it's a good question. I think
Mm,
the trust is that it's kind of, I can figure this out. Do I trust a relationship? I think you got
Mhm.
to be able to trust the relationship with a patient, that they trust that you're thinking about them and trying to understand, and that they want to give to you to help. You've got to trust. If you've got a patient who's secretly thinking, I'm going to suicide all the time, you can't contain, right? So you've got to trust the relationship. I guess I'm not so afraid of emotion anymore. I
mm,
don't know that I ever was, but I'm definitely less so. That emotion to me is really just, it's communication. It's telling me something. I can always try and understand it. Um, it's expression. And so I trust emotion as a communicator. I have to trust my patient. I know that. And I trust that my mind will try to work and just figure it out. And I guess the patient appreciates that. Something like that.
You, you know, Robin, it's striking me now. I'm just riffing in my own mind that there's a paradox a little in the word container. Like if I see myself as a container, I got to do something um, to that, um, there's an impulse to want to kind of come up with a right answer, like you said, to kind of know something, to help someone as a container. Whereas the containing function actually is to know who is it that's here with me, to wonder about them through curiosity. But the word container, I think, can make us think that we got to do something
Mhm.
Well, I
to
find
to
that
make it
interesting.
right.
See, I don't think so. I
You
think
don't think it
container
like that?
means just give place to it. You
Yeah,
just
yeah. Well, I think that's right. But
Mhm.
and
historically, the
something
word,
goes on inside there, but
right.
yeah.
Historically, to me, though, it can make me think, oh, I've got to contain this. I've got to do something.
That
I
you've
got
got to
to,
do something to
yeah, yeah.
contain it, meaning bring down the aggression or bring
Yeah,
down the
I've got to think
anxiety
of
or
the right idea. Oh, this is this, or an
yeah,
answer
yeah,
as
yeah,
opposed
yeah,
to
yeah,
an
yeah, yeah,
understanding.
yeah,
So
yeah,
the idea of a container as as an understanding of what's being and who's being contained is just a beautiful idea to me.
yeah, yeah. No, it's actually doing less that's more
Yeah,
contained.
yeah,
Yeah.
yeah.
Yes.
Mm-hmm.
I wonder if you might say something. There's been some, a little bit of a dance in the chat, with people referencing ideas about countertransference, and which is, as part of a lot of training and development for therapists, they get exposed to thinking about countertransference and being aware of it. How do you think about some of these experiences you're containing in light of countertransference, and what might that mean to you?
Well, countertransference is a complicated thing. You can take it very superficially as just a reaction to a patient, right?
Mhm.
Um, which is something to be thought about, okay? But it can also be, that a patient is hitting on some real vulnerable part of you or some sensitive spot of you that do or do not have understanding of. Um, but I just think, if there's a soup in the can, it's part of the soup. It's okay. Well, I know that patient just said that, and yes, they stepped on something that's particular to me that I am more sensitive to. How do I separate that out? How do I use it? Um, so I think, it's about being aware of yourself and allowing that to contribute to your understanding. Or, yeah, maybe that.
Yeah, yeah, there's something about how certain reactions we have may become sort of patterns, maybe. And, we feel like I remember I've had the experience with some folks of feeling pulled to be a helper, and somehow save them from something. And then have to kind of step back and say, yeah, my tilt might be to want to be helpful to people. However, I can't ultimately fix this person's life. And what's that about right now? That yes, this is part of me and my psychology, and at the same time, it keeps coming up over and over and over with this person.
Well, for instance, the patient of mine that I would talk about with the really violent internal world, um, I have to check myself on that all the time. Am I trying too hard? Am I
Mhm.
being, am I dangerously the one and only one in this person's life? It's complicated how isolated she is, but I managed knowing that I could be drawn in to that because she is so easily to be, it's so easy to be empathic with her. Um, that I have to watch out for myself, that I've got to also get supervision or talk with other people or keep in mind my own limits and what's realistic and what isn't. And, to have to be aware of all of those things because you can get pulled into things where you're not observing yourself. I think that's a danger in countertransference.
Mhm.
Yeah.
Mhm.
There's a, a comment here from Donald Roth about up early in the chat around open awareness, which is something I'm learning more and more about. Open awareness as involves awareness of oneself, of what's going on um, between you and a client as well as outside. And it seems to me that just the process uh, of awareness actually and being present with somebody is a major component of the container that we're talking about.
Yeah.
Um, that there's a sense of really, I know people are commenting on your presence, Robin, and I think that's just it. That there's a way in which people know you're present with somebody, that is so containing, rather than the being overdoing, really.
Yeah. 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 There's something, you're not frenetic, you're not trying to fix, you're being with. And, there's a number of comments here, people referencing, and thank you, Robin. I mean, you acknowledge the reality of different practice contexts. In my view, and this is now speaking as a hospital leader, I think that leadership can play a very important containing role for staff. And if that staff don't have the sense that they're held, that they're contained, it's really difficult to be on the front lines every day.
Yes, 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 yes. Well, and Ross, this is what, Shelley does,
Mhm.
the ambit,
Yep.
that is a mentalizing program for teams, right? The importance of having a team sometime where you can
Mm-hmm.
talk to, that backup, that extra containment and processing for
Mm-hmm.
yourself or supervision,
Mm-hmm.
so important.
Yeah.
Yeah. Yeah. If you want to feel the terror of being uncontained, be in an uncontained group.
Really?
Beyond
Yeah.
what's helpful with that too.
Yes,
Contained group
absolutely.
causes insanity in all of us. I mean, it's just,
Yeah,
Yes,
yeah,
absolutely.
yeah,
Yeah.
yeah.
I'm feeling sad we have to end, Jeff.
I know.
I know. Oh,
We're gonna contain that for all of us
I
and
know.
gather again in a couple of weeks for your talk to us about trust. Yes, Michael?
Yeah.
Yes, that's right. We're going to talk about influencing, in this
Fantastic.
space, the
Fantastic.
art of influencing one another.
Fantastic.
Great.
This is a natural development from this too. Yeah,
Yeah.
I
Yeah.
just love how we kind of all,
Mhm.
yeah.
So next in 2 weeks will be our last talk of this series. So tell a friend to come and join, and I just really appreciate everybody's comments and thoughts in the chat that are so smart, so bright, and so compassionate. Really, I really do feel like we have a group that is resonating with one another, even here in 2D. So thank you everyone for being here and for the beautiful comments, and stick around for that link to pop up for the evaluation for continuing education, and we'll see you in a couple weeks.